Professor Makanwal, sir, good evening, sir.
Good evening, sir.
Thank you for joining, sir. Warm welcome to you and warm welcome to all the faculty of this evening. I also welcome the residents who have joined this evening. I could see Professor Ratna ma'am, who has permitted her PG to present. This has been a consecutive presentations from that department at Hindura. Thank you, madam. And I thank Saha sir for kindly accepting our request to be the faculty for the evening. We also expect Professor M. Rajshekhar sir. He is a professor head of the department and medical superintendent of Sri Venkateswara College of Medicine at Pondicherry. And we have Professor Kana sir, Rajiv sir, and we could see other senior faculty, Krith sir, and others are there. I warmly welcome people who are joined on the YouTube also. I wish Darshan very good luck, and I think Darshan knows how system works here. So the PG is allowed to present the history without stop, and then the faculty can revisit the slides one after the other and ask questions. Same way the clinical part goes non-stop. And then we have another half an hour for discussing the management part and then recent advances and operative surgery. So with that brief introduction, now I hand over the session to the faculty. Darshan, please introduce yourself, your unit chief, your head of the department, and start your presentation. On behalf of the faculty and resident colleagues, we wish you best wishes for the upcoming presentation. Thank you very much. Good luck to you. Faculty, please take over.
Thank you, sir. So, good evening, everyone. I am Dr. Priyadarsan from Indira Hospital. I'm a second year DNB resident. So, my guides are Dr. Ratna Chopra, who is the head of the department, Indira Hospital, and Dr. Pramod Yadav, who is my thesis guide. So, I'm going to start my presentation on thyroid swelling. So, chief complaint, 22-year-old lady, a resident of Delhi, a college student who came with complaint of swelling in the front of the neck for 4 years and complaint of pain or the swelling for 1 year. So there is an history of present illness. The patient was apparently asymptomatic 4 years ago when she noticed a swelling on the left-sided front of her neck, measuring approximately 2 into 2 centimeter, as judged by her. It is insidious in onset and remained relatively stable in size for the initial 3 years without significant progression. And it progressed gradually to the current size of 5 into 4 centimeter in the past 1 year. So the swelling of size 2 into 2 centimeter noticed by the patient at right anterior side of the neck 3 months back, which has no changes in size, which is associated with dull aching pain on left-sided swelling lasting for a few hours to the day. So these patient present associated with the pressure symptoms which are features of infiltration. She's presented with difficulty in swallowing solid foods and occasional difficulty in breathing, and there is no alteration in voices. And these symptoms associated with symptoms of hyperthyroidism, which is weight loss, heat intolerance, palpitation, tremors, hyperphagia, hair thinning, and there is no bulging of eyes or no history of insomnia noted. No history of increased sweating, no history of breathlessness on exertion, not associated with any other swelling in the neck, not associated with pre-tibial myxedema, and not associated with symptoms suggestive of distant metastasis. Past history, no comorbidities, no history of irradiation in childhood, no history of surgical intervention in the past. Menstrual history attained menarche at right time with no problem in menstruation, and patient is unmarried. So coming to personal history, patient consumes both vegetarian and non-vegetarian diet. No history of intake of goitrogens. She consumes iodized salt, and there's an increased appetite noted, and bowel and bladder habits are normal. No history of any substance abuse, and there is no history of intake of any goitrogenic medications noted, and no history of thyroid disease in the family members. So as a summary, 22-year-old lady presented with a swelling in the left anterior aspect of the neck for the past 4 years, and a smaller swelling in the right anterior aspect of neck developing over the past 3 months. The swelling is associated with pressure symptoms and features of hyperthyroidism. There is no clinical features suggestive of malignancy. So can I proceed to general examination?
Anyone wants to ask from the street? So, Dr. Makanwal.
Yeah. You said, is this two separate swelling or it's a swelling in continuity?
So these are two separate swellings. One is in the left side, which was around 4 years, present for 4 years, and the left side was noted for the last 3 months.
Okay.
Sorry,
So
left side
what do you
was
think? The
noted for
swelling
4 years,
is
and right side was
showing a
last 3 months.
gradual. Okay, fine. You said the swelling was static for 3 years, and over the last 1 year, the swelling is growing. So what do you think? Is it a slow increase or is it a rapid increase in size of the swelling?
There's a gradual increase in size. For the last 1 year, there's a gradual increase in size.
In 1 year, the swelling has become double. So you think it's a slow growth?
Yes,
You say 2 by 2,
there is not
static
a
for
rapid
2 years.
increase, but sorry, sir.
You said static for 3 years, and
Sir.
the growth has started for 1 year, and pain is for 1 year. So I think
pain for the last 3 months, and
double in
the
size.
gradual progression happened for the last 1 year.
Okay, fine. You said there are no clinical features suggestive of malignancy. So
Yes.
in the history part about your the patient has got some compressive symptom. You said patient has got difficulty in swallowing, patient has occasional breathing difficulty, and in view of this increase in size and pain, why do you say there is no features of malignancy on history? What do you expect? If it is a malignant change of thyroid gland, what symptom patient may have?
In case
I
of
don't agree to this line. I don't agree to this statement that there is no clinical features of malignancy in this swelling. I find there are some suggestions. What are the symptoms which might point, yes, there might be a malignant change in the swelling?
In case of infiltration if it is malignancy, it can infiltrate to the surrounding structures like recurrent laryngeal.
Thyroid malignancy grows very slowly. It does not go to the local structures very rapidly. Okay, if you go to the different thyroid malignancy, except the anaplastic thyroid carcinoma, other thyroid carcinomas does not involve the local structures in a span of about 6 months or 1 year. But what do you find? How do you explain a 5 centimeter swelling? How do you explain the patient having difficulty in swallowing or difficulty in breathing?
As the gland was increased in size, it causes the compression over the posterior structures, which is thyroid. So because of this, the patient may develop this kind of symptoms.
Why is the patient having pain? What is the explanation for pain in this patient who has got a goiter?
Pain, in case of thyroid swelling, if it is hemorrhage, it can cause pain.
No, that pain is different. If the patient has got a hemorrhage in a thyroid nodule, that pain is different. That pain is sudden onset pain, sudden increase in swelling. So this is not a swelling which is growing over 1 year. This is something suggestive of hemorrhage in the thyroid. So this is a dull
infection like thyroiditis can also cause pain in the swelling.
No. Do you think this is thyroiditis?
No, sir. But the pain.
Why not? The rapid increase in size of swelling is causing stretching, and this can be a pain of stretching. Or if you are saying that it is causing compression in the local structures. Okay, so it is safe not to say this line at the beginning because there are some symptoms in this patient which might point towards malignancy. Okay.
Darshan, like sir says that feature red flag sign for malignancy. So can malignancy produce hyperthyroidism? Can a malignant thyroid be hyperactive?
In most malignant of thyroid or euthyroid, there's a least chance that the malignant thyroid, which
so
is
suppose she's got two nodules, right? Can it be that one of them is a malignant, other is overactive? How do you explain? Suppose it's malignancy and hyperthyroid. Can you explain it?
Not here. It is.
So
Dr.
two tones.
Samar's asking is, can the malignant nodule be toxic or hyperthyroid? Can you have a hyperfunctioning malignant nodule? Is that what you're asking, Dr. Sahib?
Yes, yes, yes.
So in case of malignancy,
Is it common?
Is
Is it common?
chance it can be a toxic nodule.
Very rarely. Very rarely.
Very rarely.
Yeah.
Or you can explain that the two nodules, one could be a malignant, other could be a toxic. Right? Okay, let's go to your first slide. Okay. Pain over swelling for 1 year. So why do you think this patient is getting pain over the swelling?
One of the causes is like if there is a nodule which was static on a later stage, there's a pulsatile stimulation over the nodule, and which can also
Darshan, could you speak a bit slowly? I can't hear you.
So the swelling was present for the last 3 years. After, on a later stage, there's a central necrosis happen in the nodule because of hemorrhage. This process can causes the nodule to have the pain in the patient.
So hemorrhagic in the nodule, will it cause pain for 1 year or will it be a transient pain?
Mostly it will be a transient.
Right. So, I mean, okay, let's go to the next slide. Let's see what if we can pick up any call for this pain.
So thyroid has a capsule. Can stretch on the capsule be a reason for continuous pain for 1 year? Markanlal sir, would you want to speak something on that? Because thyroid has a capsule, and stretch on the capsule could be a reason for continuous.
Yes. What I'm trying to say is, this patient has got a swelling for 4 years, which was static for about 3 years, and in 1 year time, the swelling from 2 centimeters has gone to 5 centimeters. So I assume that this is a relatively rapid increase in size of the swelling, and rapid in size of the swelling can cause stretching pain in the neck. And second explanation of pain may be that the swelling is causing compression of the local structures. As he said, patient has got difficulty in swallowing, she has occasional breathing difficulty. So the compression of the local structures can cause pain because of compression of cervical plexus.
Okay. Next slide, please. Okay, associated dialectic pain.
And second thing is, you said no malignancy. Have you incurred about on the background of compression of the trachea, difficulty in swallowing, difficulty in breathing? Have you incurred whether there is any metastatic disease elsewhere in the body, and what symptom you would have asked?
Mostly.
What could have been there in the neck? What could have been there in the neck itself, if it is a malignancy?
Cervical lymphadenopathy can be seen in case of metastasis.
Yes. So he might have complained swelling away from the site of the thyroid.
Away from the
neck. And what else? Where does the thyroid malignancy commonly spread, which can produce symptoms?
So it can also spread to the other structures like lung or liver.
Where? Lung and common sites, lung and bones.
Bony metastasis also.
So what symptom you have clarified from the patient to say yes, there is no metastatic disease somewhere else? What you have asked?
So if the patient complained of bony pain or pulse because of this follicular carcinoma, patient
it can be bony pain or it can be it can be swelling in the bone and some bony swelling. And what about lung metastasis or pulmonary metastasis can cause?
So the patient will have a difficulty in breathing because of the lung metastasis.
And
so
and it can be a dry cough.
Dry cough.
It can be irritating cough because of metastasis in the pleura. Okay, dry cough. It can be breathlessness. It can be pleural effusion causing breathlessness. Hemoptysis is not very common in metastatic disease. Okay. And if the patient has got a cerebral metastasis, what symptom he may have?
Sorry, severe
What are the
metastasis.
symptoms of cerebral metastasis?
Bone metastasis. Patient have bony pain, especially over the
No. Brain. I mean brain metastasis.
brain metastasis. Headache will be
Follicular carcinomas can spread by bloodstream. Can go to
yes.
the brain also.
brain
So patient will have headache.
headache.
Patient will have headache. Patient may have convulsion. Patient may have seizures. Patient may have a loss of consciousness. Patient may have focal neurological deficit. Okay, so because in history you are supposed to write one line that there is no metastatic symptom in this patient. And here the question you should ask to say that yes, there is no metastatic disease. Yes, sir. Dr. Sahai, please continue.
Right. So, right. Okay. The next slide, please. So, difficulty in swallowing solid food. What kind does food get stuck? What kind of difficulty is there? Because the esophagus is like behind the trachea, isn't it? So very difficult for a 5 centimeter size swelling to cause dysphagia. You get me?
Yes, sir.
Yeah. So what kind of difficulty? Where was the difficulty? Which level? You'll have to be more. You'll have to elaborate that, right?
At the level of so as the esophagus is a muscular structure.
Okay. At the neck.
At the neck region.
Okay. So why do you think she's having difficulty swallowing solid food? Because it's a small swelling. It's a 5 centimeter swelling, right?
Yes, sir.
So esophagus lies behind the trachea. So why can you explain that?
So it is so because of this enlarged thyroid gland and the nodule present. The posterior to thyroid gland is the trachea, which is a rigid structure. It can easily compress the posterior structure, which is muscular. So this can.
So you mean the thyroid is pressing the trachea is pressing the esophagus?
What is the direction of enlargement of thyroid, anterior or posterior?
It's towards the anterior.
Direction of enlargement is posterior. Why?
You've got the sternothyroid, glenomastoid. It goes underneath, so that space in the neck can get constricted, and the patient may have compression. Yeah, but it is uncommon. Okay. Associated symptoms, hyperthyroidism. Okay, which of the symptoms? I don't know whether you know about Wayne's criteria, right? Have you heard of Wayne's criteria for hypothyroidism?
Wayne's criteria.
Okay. So they have classified, Wayne's has classified all the symptoms and given certain weightage to more weightage to certain symptoms and less weightage for them. So do you know which symptom has got the highest weightage?
Weight loss.
So it should be weight loss in spite of with a good appetite. You just can't write weight loss. You have to associate it with appetite. You get me?
Yes, sir.
Yeah. And heat intolerance in a normal environment. Everyone is not intolerant to it, but this person is intolerant. So these have the highest weightage and symptom. You get me? So it should be weight loss in spite of good appetite.
Good appetite.
Okay, next slide, please. Okay, why do you ask for increased sweating?
What is it?
Why did you ask for increased sweating?
Yeah, it is one of the symptoms of hyperthyroidism. Patient will have a palpitation and have an increased sweating.
So just club it together in that the slide before. Okay.
Okay.
Did you ask for symptoms of Horner's?
Yes, sir. There is no symptoms of Horner's.
Yeah, so they should write about it. Write it up, right?
Okay.
Not associated preterm. Then what about postural muscle weakness? Proximal muscle weakness. So if you're listing out, look, either you write no symptoms suggestive of hyper or hypothyroidism, or if you're listing out the symptoms, then you list all of them. You get it? So it is very incorrect to list the symptoms because there are numerous. Hyperthyroidism has having 40, 50 symptoms. Vague ones. You can't list all of them. So it is better to write. If someone asks you, just say yes or no. Okay?
Yes.
Yeah, next slide. Irradiation. She's how old is she?
22-year-old.
Okay. So how long does it take? Irradiation at birth?
At 5 years, less
5
than
years.
5 years.
Okay. Takes up to 10 to 15 years. Okay, next slide, please. Okay. So if she was hyperthyroid, what would we expect in her menstruation?
Patient will have polymenorrhea in case of hypothyroidism.
No, one is increased flow, and the other is decreased period, decreased time. Is it occurring more frequently, or is the amount more?
In case of hypothyroidism.
Mm-hmm.
What are the
Patient also have,
what are the different menstrual abnormalities in a patient who has got a hypothyroid vis-a-vis a patient having hyperthyroid?
in hypothyroidism, a patient will have an oligomenorrhea present.
No, hypothyroid is not oligomenorrhea. Hypothyroid patient has more incidence of menorrhagia.
Yes, it's the other way. We all
Daily
see that,
periods.
right? They have increased flow in hypothyroid.
Okay. In hyperthyroidism, patient has hypomenorrhea
Yes.
or even amenorrhea. Okay, so don't confuse.
Okay.
Next slide, please. Vegetarian. What goitrogen?
What do you mean by he has no history of goitrogens? What you have asked? What goitrogens common people take?
There are some vegetables like cabbage, kale, these vegetables are goitrogens, which can cause.
Why are these? Okay, why are these vegetables goitrogen? This is brassica family. What is that thing?
These families can. They involved in the organification of the iodide.
No, what do this fabric? What does this vegetable contain?
It contains thiocyanate.
Yes, they contain thiocyanate. Right? And you know when thiocyanates act in physiology of thyroid? For instance?
Conversion of iodine into iodide.
Uptake, right?
Uptake.
Okay. Now you're writing increased appetite. Look, Darshan, your out there you not mentioned appetite, right? So, yeah, again you come down to drug history of intake of goitrogen medication. You know, you are going to invite a lot of questions this way. It's good in one if you know about it. Okay, tell us about goitrogen medication. Let's set it 4 hours.
Mostly antithyroid drugs or para-aminosalicylic acids.
Hardly used. There were some more common ones.
Amiodarone can cause.
Amiodarone one. What else?
Even antithyroid drugs can cause which are the goitrogenics.
Okay, more important one. Okay. So in Harrison, there's a whole I think 3 or 4 pages that will list out all the medications and all the various things. One goes with them. Okay. Right. Okay. Family history.
In family history, you say no thyroid disease in the family members. Patient has got a thyroid swelling. There is some suspicion of malignancy. Is any other history important in the family? Can there be any other related malignancies? or other diseases which might be there in the family?
There are other diseases like Men's syndrome, which also
Yes.
progress to the family members. If
Yes.
the family members having pheochromocytoma,
Yeah.
so this can cause then pass the medullary carcinoma to the next generation.
Yeah. So you should ask about the other, not only thyroid disease, whether some other family members has some abdominal operations in the form of some adrenal tumors or not. Okay. So other related malignancies are also important as part of immune syndrome. Sir, I think I'll pass on to examination.
Yes, sir, please.
Yeah.
Darshan.
Yes, sir. So on general examination, patient was examined in a well-lit room with adequate exposure in a sitting position after taking a due concern and in the presence of a female chaplain. Patient is moderately nourished and thin-built. Patient is conscious, oriented, afebrile, and hydration is fair. BMI of the patient was 16.6. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema noted. Vitals. Patient's pulse rate was 73 beats per minute with a regularly irregular rhythm and a normal volume. So blood pressure of the patient was 110 over 70 mmHg measured in the left arm with patient in sitting position. SpO2 was 98% with room air, respiratory rate was 16 breaths per minute, and temperature was 98 degree Fahrenheit. So after obtaining a verbal consent, patient was examined in a well-lit room in a sitting position at eye level and also with the examiner standing behind the patient. So on proceeding to the examination of the neck, on inspection, attitude of the neck is normal with trachea in center and no visible veins or pulsation noted. Neck appears asymmetric with visible swelling on the left side of the neck. So a single bovoid swelling of size approximately 5 into 4 centimeter in the left anterior aspect of the neck, which moves with the deglutition and not with the protrusion of tongue. So there is no scar, sinus in the neck. There is no other swelling visible on the neck. So on palpation, there is no local rise in temperature noted and non-tender. Thyroid gland is enlarged and palpable with evidence of bilateral thyroid swelling. The left lobe being larger than the right. A 5 into 4 swelling in the left anterior aspect of the neck, ovoid in shape with well-defined borders, which is firm in consistency, regular margin with smooth surface, and intrinsic mobility of the thyroid is maintained. Extent superiorly up to the level of lower border of thyroid cartilage. Inferior border is palpable and it is 3 cm above suprasternal notch. Medially reaches the midline of the neck and laterally up to the anterior border of left sternocleidomastoid. And another swelling approximately 2 into centimeter size is noted in the right side of the neck with no local rise in temperature redness, which is firm in consistency. It has a well-defined border and smooth regular margins. The extent of the second swelling is superior up to the level of lower border of thyroid cartilage, inferiorly 4 cm from suprasternal notch, medially 2 cm lateral to midline of the neck, laterally up to the anterior border of right sternocleidomastoid. So other than this, no other swelling in the neck is noted. You can able to palpate the lower border of both the swellings, no thrill present. Common carotid pulse is palpable on both sides of the swelling and trachea in midline. So other system examination are normal in age and there is no high signs suggestive of hyperthyroidism. So as a summary, a 22-year-old lady with an irregular pulse rhythm presented with a 5 to 4 centimeter ovoid firm swelling the left lobe of the thyroid with a smooth surface and a well-defined border. A second firm swelling measuring 2 to 2 centimeter noted in the right lobe, also with well-defined border. The swellings are associated with features of pressure symptoms and clinical signs of hypothyroidism.
Please.
Okay, come to your the first slide of the examination. First slide, general examination. First slide.
Yes, sir.
First slide, general examination.
Yes, sir.
General examination. First slide.
Yes, I said.
General
General
examination.
examination.
Yes, you said patient is moderately nourished and say thin built. What do you mean by thin built? What do you mean by built when you're describing general examination? There is nothing called thin built. Built is a skeletal structure.
Skeletal muscular structure.
Patient is average height, or patient is having stunted growth, patient is having gigantism. So this is nothing called thin built. Either patient is average, that means depending on the sex and race, patient may have an height of 5 feet 2 inches, or patient may be of good height. So it's a structure, not thin. Second is you are saying the moderately nourished, and you are saying BMI is 16.6. What does it mean? What is the normal BMI? Patient having a normal weight vis-a-vis the height. So what is the range?
Within 90 to 23 is normal.
No. 18 to 24. Okay. So that is the range of normal nutrition. You are saying patient is moderately nourished, and you are saying BMI is 16.6. Somebody having 16.6 BMI, I will say the patient is malnourished. Body weight is less than the expected body weight. Next slide. Okay, come to the examination of thyroid. Next. You are trying to say that there is a swelling involving the right and left lobe of the thyroid gland. Is it right now? There is a swelling involving the both lobes of the thyroid. Left is more, right is less. Is that the finding on examination?
So there is an enlarged thyroid gland with the two nodule, which is bigger size in the left side and the smaller
I'm saying that is I'm saying. In that case, is there a confusion to make a differential diagnosis with thyroidal cyst?
No,
not at all.
No.
Then
it is in the upper border of the neck.
And then you this part next you are trying to say that no protrusion, no swelling movement with protrusion of tongue. That test is not required. All test is not to be done in all places. You are saying there is a swelling involving the both lobes of the thyroid gland. So it's a thyroid swelling. There is no question of making a DD with thyroid cyst. Don't do this test. Skip that part. Okay. So there is a swelling involving the thyroid gland, involving the both right and the left lobes. And you describe the dimension of each of the lobe. You have described. Okay. What about the midline area? You try to mean that the isthmus area is not enlarged? Is there two separate isolated swelling on each lobe? Which is not very common.
No, so because entire thyroid was enlarged and is palpable also.
So it's a diffuse thyroid swelling then. Okay, try to be describing clearly the clinical finding. Next slide. Next. So once you describe the thyroid swelling, there is a pattern of describing. In the lobe, what is the extent of the normal thyroid lobe? Normal, not enlarged. Extent of the normal thyroid lobe, above, below, medially, laterally.
Normal without enlargement, we can't palpate the normal thyroid lobe. If it is
I'm asking a simple anatomical question. What is the extent of the normal thyroid lobe above? How far it goes above?
Upper border of thyroid cartilage.
There is a oblique line in the thyroid cartilage. There is an oblique line which is reaching up to the upper border of thyroid cartilage. Below, it is just from the sternoclavicular joint. Lateral border of the trachea, and laterally it is going deep to the sternocodermal striate.
That's right.
So this is a normal extent. So now once you have a swelling in the thyroid lobe, this swelling you are palpating in each of the lobe. Is it a single swelling, or you find there are multiple nodules involving each of the lobes? What is your palpatory finding?
Palpate, there is two nodules, which is left sided, there is a single nodule, which is enlarged of size 5 into 4 centimeter, and right sided, there is a 2 into 2
Now you
centimeter.
see, now the concept of nodule description is changed in thyroid. Suppose you palpate a single nodule and you do ultrasound. Ultrasound can show there are multiple nodules. So a clinically palpable single nodule may be multiple nodules. So it is sometimes a clinical examination followed by ultrasound where the finding may change. So it can be a multiple nodule. That's why now it is more commonly described as a nodular disease of thyroid gland. It's not solitary thyroid nodule or multinodular goiter. Okay. You said.
Darshan,
Yeah. Yes, sir. Please.
Darshan, you have mentioned that intrinsic mobility is maintained. What does it mean? Previous slide.
Previous slide, please.
So normally,
Intrinsic mobility is mentioned.
Normally,
Yes.
the
What does it
thyroid gland is attached to the pretracheal fascia, so which can be moved horizontally. We can't move in the vertical manner. So that's why the mobility of thyroid is maintained, which is attached to the pretracheal fascia.
Tell me why thyroid gland moves with deglutition. Tell me why thyroid gland moves with deglutition.
So as it is attached with the pretracheal fascia, so on deglutition, these oblique muscles of the pharynx get contracted. So while along the movement of the trachea, it also moves the deglutition as it embryologically attached with the thyroglossal duct.
What moves with deglutition? Only the trachea? Whole the larynx with the trachea moves up.
Darshan, it is PG case presentation.
While deglutition hold the trachea larynx, because of the contraction of the oblique muscle of pharynx, the entire trachea with moves along with the thyroid gland.
Not correct. Partially correct. Other two explanations.
Where is the Berry's ligament attached? Where is the Berry's ligament attached?
Attached to the behind the thyroid gland, which is the condensation of the pretracheal fascia.
Where
Posterior
is the Berry's gland attached in the larynx?
Posterior to the thyroid, it is attached to the pretracheal fascia, which is the condensation of pretracheal fascia.
No. It is the condensation of pretracheal fascia. From thyroid, it gets thickened and gets attached to the cricoid cartilage. Berry's ligament is a condensation of the pretracheal fascia which gets attached to the cricoid cartilage. So apart from pretracheal fascia which is attaching the thyroid to the trachea, it is also attached to the larynx. So as the deglutition, the larynx and the tracheal complex moves up, the thyroid moves up.
What is natural history of goiter formation? What is natural history of goiter formation?
So it starts with the diffuse hypoplasia of the thyroid. So due to the continuous stimulation of the thyroid gland, then it follows the after later stage there is an pulsatile.
What is first stage? What is second stage? What is third stage? What is first stage?
What happens in the first stage?
What is
the cause behind it?
Because of stimulation of the thyroid gland, the TSH becomes more TSH. Continuous stimulation can cause diffuse hypoplasia of the thyroid. This is the first stage, followed by the
yes. So this is a 24 this is a 24 years old girl. She is.
So what is?
Yeah.
What is colloid goiter then? What is colloid goiter?
So after the later stage, there is an inactive nodule formation with internodular active.
No. Nodules won't come in a colloid goiter. diffuse enlargement of the
filled with the
gland.
colloid, but there
Diffuse
is
enlargement of the
nodular
gland having soft
active.
in consistency, filled with a colloid matter, that is called as the colloid goiter. That is the end result of the first stage of the goiter. End result of the first stage of the goiter is the colloid goiter. And colloid goiter it is due to the persistent stimulus and uniform enlargement of the gland. And in second stage there is a fluctuation in stimulus. So there is some nodule formation is there. So nodule formation is second due to the fluctuation in stimulus. And in third stage there is the nodules. Internodular tissue is more active.
Internodulars are more active.
So that is toxic goiter. This is natural. This is called as natural history of goiter formation. Okay, proceed. Continue, sir.
Yeah. You said there are no. You said apart from the thyroid swelling, you said there is another swelling you described. What is that swelling?
There is no other swellings other than the thyroid.
Oh, you are trying to mean that the right lobe you described separately, yeah?
In thyroid only, in thyroid area only, there are
okay.
two swellings.
Okay. Have you examined for some toxic signs in this patient?
Or is it?
Have you looked for any toxic signs? You talked about toxic symptoms. Have you looked for toxic signs in this patient?
Patient have this regularly irregular pulse rate.
So toxic sign one is pulse. What else?
And
what are the toxic signs you examine in a patient who are present with thyroid swelling? One is pulse.
Pulse rate.
What else? Pulse.
Cardiogenic features.
You don't look at the eyes. You don't look at the eyes.
Eye signs also.
Eye signs. Yes. So pulse.
Like
eye signs.
Pulse, eye signs.
Then some neurological signs. Tremor, fine tremor.
But tremors present with the tremors with a speech of hypotension also present with
the
and palpitations.
Palpitation is not a sign. Palpitation is a symptom. I am asking signs. Tremor. What else? Can there be any muscle weakness in patient with hyperthyroidism which you can test? Which muscle weakness is predominant in patient who has got thyroidopsychosis? Distal muscles, small muscles, or proximal muscle?
Distal muscles.
No. Proximal muscle weakness is predominant in patient who has got hyperthyroidism. Hyperthyroid patient may have proximal muscle weakness that you can test by asking the patient to stand up from the sitting posture. So patient has difficulty in standing up from sitting posture. Okay. So that in and what about some other findings which can be present, like patient may be swelling in the legs, which is non-pitting.
Vertebral mixed edema.
Yes. So you should also be examining these signs because you said patient has got a non-toxic nodule, no?
Yes, in the history you said about the...
Yes, sir.
Yeah, in the history you said about the patient is having a pretibial myxedema. Now, that is a sign, that you have to demonstrate, and you have not told anything about in the sign about the pretibial myxedema. Pretibial myxedema is a feature of hypo or hyper?
Hyper.
Hyperthyroidism. Okay. And then you said her hairs are brittle. Did you examine in the examination that her hairs are brittle?
No, sir, it comes from the patient's history, sir. she say complaint about the face are thin and
Okay. Now, in the neck, did you examine the lymph nodes here?
yes, sir.
Yes, he says.
Examine and there is no cervical the different nobody.
Okay. And in the carotid pulse, do you just see that it is palpable or not, or something else you want to tell? In the carotid pulse, in a patient who is having the obstructive features, will you just say that the carotid pulse are?
We should palpate the carotid pulse for its location. It is present or not. If it is not present, it also one of the suggestion of malignancy, which involves the carotid sheath.
One is it may not be present, and second is you say it's a
normal location. Okay.
Normal location.
Whether it is present at the normal site or not, because this may be displaced. In a patient who has got a huge multinodular goiter, the carotid pulsations will be there, but they will be displaced.
Displaced.
So you have to tell about that whether it is present or not, and whether it is at its normal location or not. Okay.
If you want to auscultate for looking for bruit in the thyroid gland, where do you auscultate?
Lower border of thyroid gland.
Is it?
No.
Is it easier to auscultate lower border and get the palpable thrill or auscultation bruit? No. This is done at the upper pole. You can easily auscultate the upper pole area where the superior thyroid vessel is entering the thyroid gland. So thrill is easily palpable in the upper pole, and you auscultate near the upper pole thyroid gland. Dr. Khanna, what do you feel?
Yeah, it is. Do you have can you just tell where is the superior thyroid artery and where is the inferior thyroid artery in relation to the thyroid?
Superior thyroid artery in superior pole lateral.
It is at the superior pole, superior thyroid artery, along with the superior thyroid vein.
Pole and superior lateral border it will attach.
Is the inferior thyroid artery at the inferior pole? No, it is not there.
In between, middle of the.
Yes, almost about the middle of the thyroid. It is there.
Get divided into both the lobes.
So, what is there at the inferior pole? Which vessel is there at the inferior pole of the thyroid?
While you operate, you need to ligate one important vessel in the lower pole. What is that vessel? It's not inferior thyroid artery. Inferior thyroid artery is at the lateral border of the thyroid gland. What emerges at the lower pole?
It is the inferior thyroid vein which is there. Okay. Okay, the vein is there, not the artery. Okay. So that is why you auscultate at the upper pole, because superior thyroid artery is at the superior pole, while inferior thyroid artery is at almost middle of the thyroid. It is quite deep seated. It is coming behind the carotid sheath. So that is why you have to always auscultate for the bruit over the upper pole. Okay. How did you check for the tremors in this patient?
So to look for the fine tremors, ask the patient to extend the both upper limb of the patient and look for the fine tremors.
How did you look for the fine tremors?
What do you ask the patient to do?
To extend the both the limb of the upper limb of the patient. Or even if it is difficult, even you can also go for the shadow sign to look for the fine tremors.
No, but how will you see? Once the fine tremors are there, you won't be able to appreciate that. So what is the thing you have to do to make it appreciable? You have to put a piece of paper over the dorsum of the hand
and put the light above the hand so that the shadows will get enlarged, so the fine tremors can be visible at the paper.
Sorry?
You
put the paper at the bottom of the hand and put a light above the hand to look for the shadow of the hand. So the shadow get enlarged, so the fine tremors
Okay.
can be easily visible.
No.
Yes,
like
just simply say that you will put a piece of paper on the dorsum of the hand and you will observe for the movement of the paper. Okay. Yeah.
Okay.
And you have to show that if there's a fan is there, that fan is off. Okay, that fan is not running. Then you will demonstrate. How do you demonstrate it in the tongue? What is that called as if you have to demonstrate in the tongue? What is that called as?
Will you ask the patient to protrude the tongue out of the oral cavity, or what do you say? To look for tremor in the tongue, patient should not protrude the tongue beyond the lips. A normal person may have some fine tremor. So ask the patient to open the mouth, rest the tongue on the lips, and look for fine tremor.
Okay, so you look in the tongue, the fasciculations which are there. No?
Yeah.
Did you test for the reflexes in this patient? You know, you are telling the patient is having hyperthyroidism. Did you check for the
this patient does not have hyperthyroidism. No.
No, he says that it's a hyperthyroidism. Isn't it?
No, this patient does not have features of hyperthyroidism. He has negated.
He has negated that?
Yes.
No, there are clinical signs.
No, he's telling about the pulse rate, which is irregular pulse, which is there.
There are clinical signs of hyperthyroidism present in this patient.
Is present?
Yes.
What he's saying, it is present, sir. Yeah.
No. He said no symptom of hyperthyroidism.
No, sir. In a clinical history, she had a weight loss, in heat intolerance, everything was present.
He has weight loss, but other symptoms you say no. And what about the clinical signs? Are there any signs which suggest patient has got hyperthyroidism?
No, sir, no signs. Patient had a tremors that was mentioned. Tremors, and there's a irregular pulse was present.
You know, once you get the patient is having irregular pulse is there, then what other thing you have to examine to see that what is that irregular pulse?
So for the pulse, we have to look for the rate, rhythm, and also the volume of the pulse to differentiate from the other.
That is for the pulse, yes. Anything else you have to examine at the same time?
We look for the other hand peripheral pulses also, and we should go for the ECG.
No.
You have to check for the heartbeat in this
other
patient.
pulses also irregular.
Okay.
Anything in the heart.
Yeah, you have to check for the heartbeat here. So the pulse rate and the heartbeat, you have to see whether they are matching or not. Okay.
So patient has some overlapping features. Okay, although patient does not have florid symptoms of hyperthyroidism, you are saying that patient has got weight loss because you said BMI is 16.6, which I consider as patient is malnourished. You cannot say patient is moderately nourished on the background of BMI of 16.6. Loss of weight, irregular pulse. So there are some suggestion that this patient might have some incipient hyperthyroidism. What is your diagnosis then? What diagnosis you made at the end of your history and examination? Give us your diagnosis.
My professional diagnosis is toxic multinodular goiter.
You say toxic multinodular goiter. Give a good diagnosis. That is not the only diagnosis. 24 years girl presenting with
bilateral thyroid swelling with pressure symptoms and without clinical evidence of malignancy.
So is it toxic multinodular goiter you want to mean? So what are the points in favor of your statement that patient has got a toxic MNG?
So, as I said, patient having this palpitation and irregular pulse, and also the features of hyperthyroidism was present with tremors and all.
Try to go back to the history. Patient has got a swelling which is there for 4 years.
Yes, sir. But the
4
last
years.
3 months,
3
he
years,
had
3 years patient has a static swelling, and all the symptoms has come up in last 1 year time.
last 1 year.
The increase in size and the symptoms you are trying to describe. So, what are the points in your favor of saying is a toxic goiter? One is weight loss. You want to mean?
Weight loss is there, and the features, some features of hyperthyroidism is there, with the with this irregular pulse and palpitation tremors are present. These things are happened in the last 3 months.
No. You have not commented about the tremor in this patient. Does this patient have tremor?
Yes, I mentioned in the history part.
Patient has got tremor.
On examination, the tremors are present or not?
Yes, sir, present.
They are present. Did you check for the eye signs here?
Yes, I checked and there is no eye signs.
There are no eye signs. Okay.
No eye signs.
So the feature of hyperthyroidism in this patient is the weight loss is there.
Weight loss, heat
Irregular
intolerance,
pulse is there.
hair thinning is there, pulse.
Tremor is there.
And irregular pulse.
Irregular pulse.
No thrill or bruit is there in the thyroid gland itself.
No, sir.
Okay. How will you proceed now?
So next, so after this clinical histories and examination, I like to go for an ultrasonography. I mean imaging, which is basically ultrasonography, mostly with the Doppler study look for the vascularity.
What is the quadruple testing for the thyroid?
There is a term called quadruple assessment, like breast. Quadruple assessment for thyroid swelling. What is that?
Quadruple start with the clinical history and examination, then followed by the
second
imaging.
Is?
What is the second one?
Imaging, which involves ultrasonography.
The second is not the imaging.
Sorry, thyroid function test.
Yeah.
So thyroid function test and followed by an imaging, which involves an ultrasonography. And if we suspect a retrosonal goiter, and also go for a CT scan.
No. Depending on the ultrasound finding, you might consider doing a FNA from the thyroid gland. Not all patients require FNA ultrasound examination. Some ultrasound examination may suggest you that this patient does not merit to have a FNA. Okay, so this is quadruple assessment. So after clinical examination, as the patient has got a suspicion of hyperthyroid features, you would like to do thyroid profile.
Yes.
What do you expect? What do you expect thyroid profile?
So in a thyroid function test, we have to look for the TSH, T3 and T4 values. Since I am suspecting a hyperthyroidism in this patient, we'll expect the low TSH level. So if this low TSH and hyperthyroidism patient, and we also go for the thyroid scan for this patient.
Then wait. Scan is afterwards, not now. First is you are doing thyroid profile study. TSH low, and what about T3 and T4?
T3 and T4 maybe normal in range or higher in range.
What is in your case? Have you done the thyroid profile in your patient?
Yes, sir, it was normal.
Normal?
Yes, sir.
And TSH was low?
TSH is also normal.
Normal?
Yes.
Fine. That is the point I want to emphasize. A patient may have some features which may not be always equating with hyperthyroidism. So now the thyroid profile is normal. We have to explain this symptom with other things. So patient is euthyroid, you mean?
Yes, sir. Euthyroid.
Fine. Next test is the ultrasonography. Okay.
Yes, sir.
How is ultrasound important? Based on your clinical examination, how is ultrasound important to give you some information based on which you can decide about the next planning. What ultrasound can give you information and how is this information comes to you. They give a pattern of report based
Ultrasound,
on
we have to, it is important to rule out whether it is an, malignancy. It can easily differentiate benign and malignant condition of a thyroid. So,
they
first,
take into
it
account
is an
some points.
iso.
What are the points? And based on that, they give a radiology report based on thyroid.
So, in case of hypoechoic, it considered a malignancy. In case of hyso or hyper, it is benign. And regarding the calcification, if it is microcalcification, considered the malignant. Macro, it is benign. Then ultrasound also shows the invasion of the nodule.
First mention the points they assess. They assess the ecogenicity of the nodule, ecogenicity, microcalcification, and what about the nodule shape?
Shape.
Is it important?
Taller than wider, or it also shows the invasion and irregularity of the invasion, capsular invasion or other such invasion, and border irregularity. Border irregularity.
Yeah. So taking into this consideration, how is the thyroid reporting comes?
Thyroids. So if it is one, it is non-neoplastic, normal thyroid function. If it is one, they mention it is a benign, and
one is not benign.
Normal.
Two is benign.
Two is benign.
One is inconclusive.
Needs
further imaging. Thyroid 1 is patient needs further imaging. Thyroid 2 is benign.
2 is benign, and 3 is probably benign, and 4 is suspicious of malignancy, and 5 is probably malignant, and 6 considered a biopsy proven.
3 is atypia of undetermined significance, or FUS, follicular neoplasm undetermined. Okay.
Yes.
So when will you consider doing FNA in this patient? This patient has got 2 nodules on the right side and 2 nodules on the left side, 2 nodules on the right side. Based on what criteria you will consider doing FNA in this patient? Would you do FNA in this patient?
No, sir. If it is toxic,
toxic is out. You already said the thyroid profile is normal.
So if it is normal, we can go for FNA.
Never forget that I already discussed with you. This patient has got pain which is recent onset. This patient has got a swelling which is showing rapid increase over the period of last 1 year. Patient has got some compression symptom. So the chance of malignancy is higher. So based on the ultrasound report, you have to consider doing FNA in this patient from the suspicious nodules. And this FNA should be what? Unguided FNA or ultrasound guided FNA?
It should be ultrasound guided FNA.
Yes. And once the FNA is done, again FNA report comes in a system. What is that?
But this is the classification
yes.
Of the thing is. So in FNAC, it can be classified in 5. It is Thai 1, it is non-neoplastic, and 2 is benign, 3 is follicular, 4 is suspicious of malignancy, and 5 is malignant.
So suppose I give a scenario that this patient FNAC report has come up as papillary carcinoma in the left lobe. what should be your next approach? The FNA report has come back to you as papillary carcinoma. What should be your consideration in this patient next?
Then we should go for the surgical intervention, total thyroidectomy.
Any other workup for this patient?
We should do the CT scan, CT head and neck, to look for any invasion or extension of the carcinoma.
You always need a CT scan. You said the swelling is showing increasing mobility. Swelling is palpable, well palpable. Ultrasound has given you good information. All thyroid swelling does not need CT scan.
Okay.
So these patients should be evaluated. If the patient FNA report comes as medullary carcinoma thyroid, what should be your approach?
So medullary carcinoma
is it same?
So we should
is the management same for papillary
look for
or
the serum?
Yes.
First, we should, if it comes as a medullary carcinoma, first we should look for the calcium level, serum calcium level of the patient.
Only serum calcium?
Sorry,
or some other marker is elevated in medullary thyroid carcinoma apart from calcium?
Calcitonin can be used.
Serum calcitonin, yes. And patient having a medullary thyroid carcinoma, you need to exclude something else also before you proceed for management of thyroid itself.
Yeah.
What else may be associated with medullary thyroid cancer?
Parafollicular cells are associated.
Parafollicular cell is the origin of medullary thyroid carcinoma. What else need to be excluded in a patient who has got medullary thyroid carcinoma diagnosed on FNA? Will you proceed for surgery straight away based on the report that patient has medullary thyroid carcinoma, or like to exclude something else?
Cochlear biopsy can.
No, not focal biopsy. You have to exclude other MEN associated tumors.
You to look for the Men's syndrome.
Okay.
Having medullary
Men's syndrome. Okay. So
Men's syndrome.
So it is also associated with.
How do you exclude? What investigation asks for?
We should go for the urine examination, 3 days urine examination for catecholamines to rule out pheochromocytoma. And it is associated with Men's syndrome.
Serum metanephrine.
Serum
Urinary VMA, and an ultrasound abdomen. Ultrasound abdomen is required to exclude adrenal lesion. So you cannot operate a patient of medullary thyroid cancer without excluding these other associated malignancies. Sir Khanda sir, please continue.
What is MEN? Sorry, Darshan. What is MEN1 and MEN2?
Sorry, sir.
What is MEN1 component? And what is MEN2A and B?
One composed of pituitary adenoma and pheochromocytoma and pituitary adenoma and parathyroid carcinoma.
2A, 2B?
Pancreatic carcinoma. The 2A involves the medullary carcinoma with pheochromocytoma and
these are basic questions. Darshan, these are basic questions. What is arterial cell carcinoma?
Pardon?
Ductal cell carcinoma.
Hardware cell carcinoma. Why does it happen?
Anaplastic.
Not anaplastic. No, hardware cell are not anaplastic carcinomas.
This is variant of follicular carcinoma.
A variant of
What is MEN2B?
What is the additional feature in?
These are
What
the
is the
basic question examiner will ask to test your knowledge.
Listen, if your patient has got a pheochromocytoma and he has got a thyroid cancer, both has to be operated. Which one you will operate first?
pheochromocytoma should be operated first.
Why pheochromocytoma first?
As it involves the adrenergic, catecholamine's adrenergic hormones, so there is an increased chance the patient having cardiac issues. So we should go for the pheochromocytoma surgery first.
Yeah, hypertension, hypertensive crisis which is there. So to take care of a hypertensive crisis which is there, that is why the pheo has to be operated first. Okay. Now, before you go for the total thyroidectomy, what are the other investigations you are going to carry out?
Other than FMS.
What other investigations you are going to?
You have to do some workup before you go for a total thyroidectomy.
So basic biochemical parameters, and they also go for the
basic biochemical and also chest X-ray and
ECGs to be done.
And what about the examination from ENT department?
We also go for this indirect laryngoscopy for the vocal cord condition.
Yes, you need to do a indirect laryngoscopy because some patient may have asymptomatic vocal cord palsy that you need to substantiate before you pass on to the 12th thyroidectomy operation.
Will you do the X-ray of the neck? Plain X-ray of the neck will you do if you are not doing the CT scan?
X-ray of the neck.
This patient you described. No. This patient you described because you said patient has got occasional breathlessness. Is a plain X-ray in the neck important?
In the neck, you can look for the tracheal position.
Yeah.
If it is tracheal deviation is there, the X-ray neck can useful to look for it. And the patient
deviation will be seen on which X-ray?
Anterior posterior.
So you both anterior posterior as well as the lateral view also.
Lateral.
Yeah.
So in the lateral view, what are the things you see on lateral view?
About the tracheal position, the compression of the trachea can be seen.
So tracheal compression is seen on the lateral view.
Lateral.
Tracheal position is seen on the AP view. So what is the significance of that to the surgeon and to the anesthetist?
Once it is compressed and there is difficulty in the intubation of the patient, so
with what anesthesia should be ready? With what anesthesia should be ready in the theater? You have a demonstrated tracheal compression, trachea is displaced. So the anesthetist should get ready with something in the theater before he gives the patient muscle relaxant.
flexible.
Yes. So you have to have a facility for endoscopic intubation. And if you have a long-standing goiter, trachea being compressed, what should be your thoughts in the perioperative period?
What is it?
Long-standing goiter, trachea is compressed. You are doing a total thyroidectomy. What should you consider in the perioperative phase?
I can't get your question.
What is that condition called as?
Can there be any problem?
What is that condition called as? If there's a
Can there be any
long-standing
problem in the
goiter is
post
there,
period?
you get tracheomalacia or scabbard trachea. You know? So if you find a scabbard
So in the
trachea or the
post period,
tracheomalacia is there,
yeah.
then what you have to do after your surgery?
So after total thyroidectomy, you have to monitor the patient, look for the post-op complication. Is there
You may have to do the
and we have to
tracheostomy in
monitor.
that patient. You know?
Okay,
Okay, tracheostomy may be required for that patient temporarily.
You said lymph nodes are not palpable and it's a papillary carcinoma thyroid. Would you like to do a elective lymph node dissection in a patient who has got papillary carcinoma thyroid, or you just do a total thyroidectomy? What is the recommendation?
Just just total thyroidectomy. Then a central neck nephrons can be removed.
What is the strategy in medullary thyroid cancer? No, N0 neck. N0 neck.
The delphin, I think delphin lymph nodes should be removed. Delphin lymph nodes should be excised.
In medullary thyroid carcinoma, recommendation is to do a central compartment neck dissection. In papillary carcinoma, recommendation is not to do a routine central node dissection. So what is the boundary of suppose you are going to do a central neck node dissection? So what issue you should clear in the neck? What is the boundary of central node dissection? Above, below, on either side. Darshan? Darshan? You said you will do a central node dissection. So what tissue you should clear up? What is the boundary of that area we called as central node or level 6
central
node?
node should be the level 6 node should be the midline with the borders.
Midline is one line, but it's an area. It's an area. Midline is one line. It's an area. Above is
the thyroid correlates, lower border of
no.
upper border.
Above is thyroid. Above is thyroid. Below is suprasternal node. Up to the innominate vein. Up to the innominate vein. On either side,
sternocleidomastoid. Sternocleidomastoid.
On either side, medial border of internal jugular vein. So if you are doing a central compartment dissection, you have to clear up the lymph nodes and the loose veinar tissue in this area, which is described as central compartment or level 6. Extending above up to the hyoid, below up to the suprasternal notch, on either side up to the medial by internal jugular vein. Okay? In medullary thyroid cancer, it is a recommended procedure to be done with total thyroidectomy. Okay? So you have done a total therapy for a papillary carcinoma thyroid patient, and in the post-op period, there are some complications. How do you detect post-op complications in a patient who has got a total thyroidectomy? What are the important complications that can come up in the immediate post-op period?
Most commonly, hemorrhage can happen, and if the patient hemorrhage can happen, and if the patient complaint of difficulty in breathing, there
So
will
hemorrhage
be
is one complication.
leakage
Yes,
inside.
this can happen in the same evening, next morning. So hemorrhage is a complication which
Hemorrhage
needs to be addressed immediately. So hemorrhage is one. Second,
patient if the patient complaint of difficulty in breathing, there is a tense thing can happen. So we should remove stitches of the
no, I'm not
suture
asking
to
management.
release
I'm
the
not asking management. I am asking the complications first.
Okay.
One is hemorrhage, you said. Second important complication in immediate post-op period is
unhope.
ready? This is the most important complication. People are worried about it. This can happen on TV.
So recurrent laryngeal
Yes.
injury can
Recurrent
happen.
palsy. Yes, either on one side or both sides. What other nerve may get, apart from recurrent nerve palsy, what other nerve may get injured, which is also important.
External
Huh?
External laryngeal can be.
Yes. External laryngeal nerve or superior laryngeal nerve can get injured. Yes. What other complications? Next.
So patient complaint
another important early post-op complication, which can be revealed before you discharge the patient, maybe revealed on second or third day. You have done a total thyroidectomy.
Hypoparathyroidism.
Yes,
Parathyroidism.
How patient will present?
Hypothyroidism.
Yes, sir.
Darshan, how patient will present?
All parathyroids are removed. What will be the patient presentation and how you diagnose that patient has hypocalcemia? What are the preliminary symptoms patient may have? And you have to detect the hypocalcemia before patient goes to a spasm or a classic feature of carpal spasm. That is a very advanced stage. You have to detect before that case comes up. What are the symptoms patient can tell you? You come to the ward after 24, 48 hours, patient can tell you something which might alarm you that yes, this might be a hypoparathyroid symptom. What are the symptoms?
Perioral numbness.
Yes, perioral numbness and tingling. Perioral tingling and numbness is the earliest symptom patient may have. How can you elicit some sign to say yes?
Choked sign can.
Vostek sign. What is that? What do you do?
We have to tap the chin of the patient, so the patient have a
where? Tap where?
Chin, cheek of the patient, or the peri or
Tap in front of the tragus. Okay, so patient have twitching of the face and around the
peri
eyeballs.
What is primary hyperparathyroidism? What is secondary? What is tertiary?
Primary hyperthyroidism, like in case of
hyperparathyroidism.
So primary hyperparathyroidism. There's an because of pituitary stimulation, pituitary adenomos, there's an increase in stimulation of parathyroid hormone.
Parathyroid is stimulated by pituitary.
So there's an
parathyroid is stimulated by Darshan, wait. Parathyroid is stimulated by pituitary.
Sorry, hypothalamus.
Huh? Hypothalamus. Is it? Don't confuse thyroid with parathyroid.
Acha, parathyroid. So
Asking about
Parathyroid is not
parathyroid.
under parathyroid is not under pituitary control. Thyroid is under
the
pituitary
control
control.
of
That depends on serum calcium level.
sorry, parathyroid. I got confused with thyroid.
Parathyroid is
Parathyroid
secreting
is
parathormone. Parathormone. And it's a feedback depending on the calcium level.
Calcium level.
So it is not something coming from the pituitary which controls parathyroid. No. Patient has florid features of hypoparathyroidism. Patient is having spasm. How do you manage in the ward? How do you manage post-op hypoparathyroidism? You have to send a serum calcium to confirm.
Level. So
you have to send a serum calcium to confirm your
level.
diagnosis. How do you manage now?
So with the calcium levels are lower level, we have to give the calcium gluconate to the patient.
What is the management in the ward? What you give this patient to relieve this severe spasm he is having?
We should give calcium gluconate as an infusion to
first you give a bolus. You give a bolus dose of 10 ml calcium gluconate slowly.
10 ml around
and then you have to start slowly. A calcium infusion. You have to start a calcium infusion. And then once this is corrected, so it can be either a temporary hypoparathyroidism because of ischemia, or it can be a permanent because you have removed all 4 parathyroids. So how will you manage the patient in the follow-up?
Follow-up, you should go for...
he cannot be on calcium infusion at home. What other drugs you prescribe?
We should prescribe as a we removing total. We did the total thyroidectomy. Patient should be under thyroid drug.
Don't confuse. Not for total thyroidectomy. Not for total thyroidectomy. If you have removed the parathyroids, all parathyroids, then you need to manage the hypocalcemia. What drug you prescribe to this patient? What drug he will need in the post-op period at follow-up? He need calcium, and for
calcium
for absorption of this calcium in utilization, you need to give the patient.
And for thyroidectomy, and we have to give a thyroxine drug also.
There is another drug called calcitriol 123 cholecalciferol, which is required for calcium absorption and metabolism. So you have to titrate the dose. Initially, you need to give the high dose of oral calcium. Okay, patient does not have any post-op complications. Patient of papillary carcinoma thyroid, you have done total thyroidectomy. What is the discharge advice for this patient? Will you start the patient with L-thyroxine, or you have something else in mind? You got my point? You are discharging the patient from the ward after 5 days. Patient has no post-op complications.
So a patient should start thyroxine.
What is the standard recommendation for a patient who has got papillary carcinoma thyroid or follicular carcinoma thyroid in the post-op period?
Patient should follow up once in 3 months post-op.
Patient?
3 monthly follow-up.
3 monthly follow-up. And what about L-thyroxine? You have done total thyroidectomy. You have not read that part. Try to understand that patient has got papillary carcinoma thyroid. You have done total thyroidectomy. You have not assessed for the metastatic disease. This patient needs a baseline whole body scanning in the post-op period. Okay.
Okay.
So when is this scan to be done? When? At what point you will ask the patient to get a whole body scanning done? And after how many days? Based on what? So
Right.
first thing is don't start L-thyroxine. The L-thyroxine which is in circulation will go off in the interval of 13 to 15 days. So patients should have increased TSH level. It should be at least 50 TSH international unit. When this thyroid tissue, if it is already there in the neck or in the distant site, will be iodine avid. So keep the patient off L-thyroxine and monitor the TSH level. And then ask the patient to do a whole body iodine scan. What are you trying to look at? In this baseline thyroid scan, what are you trying to look at in the whole scan?
In case of metastasis, there are other tissues that will take up the iodine.
Before metastasis, I have done the surgery. I may be wrong. Some amount of thyroid tissue may be left behind in the neck. So there may be some residual tissue in the neck, number one. And number two is there might be some metastatic disease. So if you have some amount of tissue left in the neck, you can measure that amount of radioactivity in the neck. So any uptake more than 4% is significant. Any uptake of more than 4% radioactivity in the neck is significant, stating that a significant amount of thyroid tissue is left behind.
Okay.
So you have some amount of thyroid tissue left behind in the neck. That is the report in the whole body scan. What is your advice now? No distant metastasis. Only some amount of thyroid tissue is left behind in the neck. What should be the management? If you have the nuclear medicine facilities, you can ablate this. Yes. You have to give a mega dose of radioiodine depending on the amount of tissue left behind. It can be anything between 25 millicurie to 50 or 100 millicurie. So you give this patient this ablating dose of radioiodine and expect that this residual thyroid tissue will be ablated with this radioiodine therapy. Okay?
Okay.
Khanna sir, Shah sir, please.
Dr. Darshan,
Yes, sir.
Darshan,
you know any tumor marker which is there for the papillary carcinoma or the follicular carcinoma of the thyroid?
Thyroglobulin.
Yeah. So thyroglobulin is one of the very important thing. Okay. After you have done your thyroid ablation, and then you have to keep the patient the thyroid replacement. No, these are two things. You know the difference between ablation and the replacement? Ablation is whatever the residual tissue is there, that is ablated by the radioactive iodine.
Yes.
And replacement is by the thyroxine. So you keep the patient on the thyroxine, and you have to follow your patient with two things. Definitely for the clinical examination which is there, you have to see if there is any nodule which is can feel in the neck. Second is the thyroglobulin, and third is the ultrasound imaging of that. So the two most important parameters in the follow-up is to see for the thyroglobulin levels, and also you have to look for the antithyroglobulins also along with that. And you have to see for the ultrasound imaging of that. Because once this recurrence is there, then you have to think if the thyroglobulin level is rising and you find a nodule which is there in the neck, then either you can go for the re-ablation or you have to go for the resurgery.
Re-ablation.
Yeah. You know what is the outcome of a papillary carcinoma of the thyroid? How much is the survival rate? What is the survival rate in papillary carcinoma of the thyroid?
Is it a good cancer? Is a very bad cancer?
Good cancer.
So
So having good prognosis after surgery.
Yeah. Okay. For the well-differentiated carcinoma which is there, we talk in terms of the 10 and 20 years, not in 5 years. You know? Other cancer we talk about the 5 years, but here we have to talk at least for 10 to 20 years survival, and it is more than 90% there. Okay, for the well-differentiated. So that is why it's a good cancer which is there. Okay, Dr. Sir, I think we can.
Yeah.
It's
Let us
already.
try can give a concluding comment. Let us try.
I think Dr. Khanna
Yeah. So what I could see was that 60 to 80% of the questions were asked and answered by the faculty, both. So there is a huge scope of improvement in history as well as examination, knowledge, and even operative procedures and skills. So I would say that all domains need to improve. He's a smart student and an intelligent student. And I think faculty needs to work hard. Yeah.
Madam, is your birthday today?
Yes.
It was on 3rd, sir. Thank you so much.
Okay, because anyway, belated happy birthday.
Thank you so much, sir. Yeah.
Thank you, ma'am. Thank you, ma'am.
So this is something that students should know per se, but he got a short notice of yesterday.
Oh, just one day.
But he made it. But still, these are questions that they should anyways know. So I think we need to work hard.
Yeah.
Thank you, sir. We enjoyed the session.
Most of the question also.
And keep presenting, Dr. Darshan.
Madam, we answered most of the question also.
Dr. Darshan,
Is it?
do you have any doubts to be clarified?
No, sir.
Right. Thank you very much, Saga sir, and all the faculty who have contributed today. Thank you, Ratnam ma'am, for permitting your PG today, and wish you a very happy and pleasant year ahead for you. Growth filled, and you always enjoy the company of students. Let that continue for many years and decades to come. Thank you very much, ma'am.
Thank you so much, sir. Thank you,
Kanakamal sir.
Thank you, sir.
Chance.
Yes, sir. Who has to give chance? You, sir. We are blessed to have you, sir. Kindly take time off to come, sir, monthly once or once in 2 months at least.
Sure, sir. Sure. Whenever you call, I'll be there.
Yes, sir. Thank you very much, sir. Kanna, sir. Any other comments, sir? Sagai, sir. Nishi, sir. Correct, sir.
Thank you, sir.
So, with the permission of the faculty, we call the session.
Good night.
Good night.